Welcome to the APAP podcast. My name is Corinne Young, and I am your host today. I'm also the president of the Association of Pulmonary Advanced Practice Providers. Today with us is the wonderful Martha Kinsman. She is a family nurse practitioner who has been working in a large pulmonary hypertension clinic in the Dallas area for 23 years. She got her doctorate in nursing from TCU in 2013. She's been published in multiple publications regarding pulmonary hypertension and in all sorts of areas, but specifically her interest is in prostacyclin titration and management of that therapy. She is a great lecturer who lectures all over the place nationally and internationally, and we are so lucky to have her. So Martha, thank you so much for joining us today and talking about pulmonary hypertension.
Oh, thank you, Corinne, for having me. I'm glad to be here.
All right. Well, let's just jump right into it. Why don't we start with talking about what's new, because there has been a lot of new things in pulmonary hypertension over the last couple of years. It's been a kind of an exciting area to be in recently. So you've seen it evolve over the last 23 years. So tell me about what's new and exciting for you.
Okay. Well, the first thing that comes to mind is the new definition of pulmonary hypertension. When I say new, it was actually published in 2018 after the Sixth World Symposium updated that definition. So it doesn't really seem new, but for us in pulmonary hypertension, it was a really big deal and certainly worth mentioning. When we diagnose pulmonary hypertension, as you know, it's by right heart catheterization, and we talk about the mean pulmonary artery pressure. And since 1972, that had always been 25. If your mean PA was 25 or higher, you had pulmonary hypertension. In 2018, they lowered it to 20. So if you happen to be listening to a lecture that was more than 5 years ago, that would be a new thing for you. So that was a really big change in pulmonary hypertension. More recent new changes would be some changes that were published from the ERS, the European Respiratory Society, European Cardiology Society. Guidelines were updated last year in 2022, and they updated, they just made a few changes to the classification of pulmonary hypertension, not anything too specific there. In the workup for pulmonary hypertension, they introduced looking at whether the patient has pulmonary comorbidities or cardiopulmonary comorbidities, and sort of splits the workup into two different approaches based on that, starting with a general care practitioner and really stressing early referral to a pulmonary hypertension program. And then also new are the updated treatment guidelines, which, again, also take into account cardiopulmonary or cardiac comorbidities, but also include risk assessment. So treatment decisions are now based on a patient's risk assessment, whether they're low, intermediate, or high risk. Those are mainly the new things that come to mind.
And the risk assessment even is kind of being looked at to be modified as well, right?
Yes, there are so many different risk assessment approaches now. Started off, quite a few years ago with the ERS-ESC group. They looked at some very large databases of pulmonary hypertension programs or pulmonary hypertension databases. Sorry, let me say that one over again. Yes, there are numerous approaches to risk assessment and more being developed all the time. The one that we're using at UT Southwestern is Reveal Lite 2.0, which is pretty easy to use, pretty fast. We've now incorporated that into our electronic medical record, and it's a pretty quick way to determine if someone is low, intermediate, or high risk. And by that, we mean risk for death within the next 12 months. So back to the treatment guidelines then, they're based on whether the patient's low risk. Those patients mostly are started on combination oral therapy, but could in some cases be started on monotherapy. And then if they're intermediate, they definitely need to be started on 2 drugs up front. And then if they're high risk, 2 drugs, and then also a prostacyclin therapy.
Yeah. What do you think about splitting that intermediate risk into low intermediate and high intermediate?
Yeah, that's a good point too. So for the 3 strata, just the low, intermediate, and high, is for the time of diagnosis. And then at follow-up, they have split that intermediate category. And I like it. I think it's really helpful because that intermediate risk category group was so big. It was about 70% of everyone fell into that. So having a low intermediate and then a intermediate high is really helpful when you're sort of, on the fence about, is this patient okay where they are? Or do we need to advance their therapy? Really, I think it was a good change.
And you use those every single visit with them?
Yes. Mm-hmm. Yes.
Yep. I think that's something in community practice that I have seen private groups struggle with a little bit with those risk factors. They're going to get it at some point during their workup, but I don't think it's as common of a practice to do it every visit. We are definitely striving to do that in our practice because we do general pulmonology. So getting everybody on board is often very difficult, and one of the reasons why they need to go to a center like yours, right?
Well, and then also there's so many different risk calculators available and not really good direction on which one to use or how to use them. So the main point, though, is just pick one and then use the same one routinely over time, like you said, at every visit.
Are there any updates in survival for these patients? I know a lot of them will Google before they come to see you, and sometimes, they really have, a group 2 or group 3 disease, but they go online and they just Google pulmonary hypertension and they're getting group 1 data. Do you have anything to share about survival?
Yes, a couple things. So back in the 1980s, the NIH had a database of patients, and at that time, we didn't have any treatment. So they were able to look at survival, and it was 2.8 years. And unfortunately, that 2.8 years is all over the internet, and oftentimes patients will think that they've got less than 3 years to live. And then sometimes there's even, older physicians who maybe haven't had a lot of experience with pulmonary hypertension and still think that that's the prognosis. And we even have patients told that sometimes. And so we have to say, oh, no, it's better now. But really, honestly, it's not that great of an improvement, but we think it's around between 5 and 7 years survival now on average based on, what reference you're looking at.
Yeah, that's a lot better. And then I'm sure with the other groups, it's even higher.
Right. We still have a long way to go, though, obviously.
Yeah. Yeah. So there are some other new exciting things coming to pulmonary hypertension, including a whole new class of drugs, right? You want to talk about sotatercept?
Sure. So currently, we have 3 what we call pathways or categories of medications that we choose from when we treat pulmonary hypertension. And those include endothelin receptor antagonists, PDE5 inhibitors, which is in this nitric oxide pathway with riociguat, and then the prostacyclin pathway. So for many years, we've had these 3 pathways. We pick one drug out of the pathway, each pathway. And so now we have this new drug, sotatercept, which had great clinical trial results in their phase 3 STELLAR study. And we expect that will get FDA approval and be available hopefully in the spring. And now it'll give us 4 pathways. And we are all in pulmonary hypertension really excited about this new medication because there's the trial data was fantastic. Their results. They met, of course, their primary endpoint, which was 6-minute walk test, and that improved by 40 meters. And then they met 8 out of 9 secondary endpoints, including functional class improvement, NT-proBNP, a range of them. And so we're very excited about this new drug.
Yeah, there's been a lot of buzz about it. So depending on when people are listening to this podcast, it may be already out and available. But right now we're still in the holding pattern waiting for it. Yeah. And it's going to be add-on therapy, correct?
It probably will be add-on therapy, but in the clinical trial, they had most of the patients were on background therapy, either dual or triple therapy, but there were some monotherapy patients. So it remains to be seen how it'll be used. I suspect it'll probably be the third, but that people still start with 2 drugs and then maybe add that as the third, but it certainly doesn't have to be that way. It is, I should have mentioned, a subcutaneous injection that's every 21 days. Not an oral therapy, but hopefully won't be.
Not even a daily therapy, which, is kind of a separation from what we've been doing with either constant infusion or, sub-Q chronic use, or oral therapy. So this is going to be something where they actually can get a little break between treatments.
Right. And then hopefully have some sort of reminder system to remember that 21 days.
Your patients don't take medications all the time on time?
Not always.
No, they don't.
I suspect
right.
they'll be getting plenty of reminders from specialty pharmacy. Yeah.
Especially from specialty pharmacy. Yeah. I would say maybe that is one place where general pulmonology might have a little bit of a head start, because we are doing biologic therapies, which are twice a month, once a month, every other month, depending on what therapy they're on. And so patients do have to kind of remember that. And we work with specialty pharmacy to make sure they're getting their deliveries and everything. So, that might be a little easier for us,
right?
Because we're used to that. So back a little bit, you had talked about dual therapy, triple therapy. Can we just touch on that just briefly for those who maybe are not prescribing regularly for pulmonary hypertension, group 1 patients? Can we talk a little bit about dual upfront therapy versus triple? Yep. I think for the most part, we all know that monotherapy is not the best standard for most patients, that the bulk of them need dual upfront therapy. So could you explain just a little bit why and what happened with the triple studies?
Sure. So the study that led to this standard of starting upfront oral combination therapy was called Ambition, and they studied tadalafil and ambrisentan compared with either tadalafil or ambrisentan alone. And the tadalafil-ambrisentan group did much better, and that led everyone to the conclusion, which we actually had already kind of been practicing that way anyway. But then we got the data that, yes, patients do much better if they're started on 2 drugs up front. And so those are specifically ambrisentan and tadalafil. Both of them are generic, so that has been a little bit helpful since ambrisentan went generic. In our practice, sometimes we use ambrisentan, sometimes we use macitentan. We feel like either one is fine, but the Ambition study did use ambrisentan and tadalafil. And as you mentioned, almost all patients need upfront oral combination therapy, and that's the approach for the vast majority of them. Now, the patients that come to us that are super sick, sometimes transferred to us into our ICU and right heart failure, and those cases will start parenteral prostacyclin. We usually use epoprostenol or sometimes treprostinil infusions, and then start them on both oral PDE5 and an ERA at the same time or shortly after. There have been a handful of patients that through clinic came in and got their right heart cath, and they had severe pulmonary hypertension. Every risk assessment parameter was in the high risk category, but either declined parenteral therapy for whatever reason. Then we'll start them on triple upfront orals with a prostacyclin analog, which is selexipag, in addition to an ERA and a PDE5. But those are pretty rare. Usually we'll do ERA, PDE5, give it 3 months, see how they're doing, do their risk assessment again. If they're not low risk, then we would add on the third agent.
Okay. Now, just for those, again, that maybe aren't prescribing all the time, or those maybe who are in a rural area and their patients either can't travel to a PH center or, are not wanting to, and they want their pulmonary person to manage their pulmonary hypertension.
Right.
Do you feel like there's a go-to therapy that might be easy for practitioners to use, that may have less side effects, easier to get, go well together?
I would say if I was in that situation, I would do my best to try to start tadalafil and ambrisentan. The ambrisentan, the ERAs are all under a REMS program because they have a risk for birth defects for women of childbearing potential. So it's a little bit more complicated. So as far as being easy to get, it does have some extra steps because the provider and the patient both have to sign into the REMS program and agree that they're not going to get pregnant. And even if you're a man, you have to do that. It's crazy. But so it's not as easy, but it's not that difficult either, just working through those steps. And then the PDE5s, tadalafil or sildenafil can be used. Sometimes sildenafil may be a little bit easier to get than tadalafil. Either one is fine. And then for add-on, if you have somebody that you feel like they're worsening and they need an add-on therapy, but they don't quite, they maybe don't need IV yet, then there's two options for oral prostacyclins, a prostacyclin analog and a prostacyclin agonist, but really they kind of work the same way. They're going to be a little bit more difficult to manage because they have a lot of side effects and they go through a titration process. So that will be a little more difficult. If there's any way at that point you can get your patient to a PH center, it's probably going to be better for you as well as the patient, because at that point they require a lot of care and a lot of hand holding and phone calls and things. Yeah.
How do you like to start your ampersand and tadalafil? Do you start them at the same time? Do you start one, then add the other one on?
I'm glad you asked that, because I have been saying upfront combination therapy. And in this clinical trial, they did that. But what we do is we'll start the PDE5 first, because it's usually they can get that the next day at the pharmacy. Sometimes there's a prior authorization, but they can get that pretty quickly. And then the ampersand, because of the REMS program, takes usually about a week or 2 weeks to get that through. So even though we call it upfront combination therapy, they're usually separated by a week or two. And that could be helpful, because then if the patients are having side effects, then it's easy to determine which drug is causing the side effects. So yeah, upfront combination therapy, but it's not really exactly upfront.
Little staggered.
Little staggered, yes.
I know I have found myself questioning myself a few times when they're also on an antihypertensive therapy, because hypotension can be a side effect of these drugs.
Yes.
And then, do I stop it? When do I stop it? Are they able to stay on it? And that's where that finessing of seeing them so frequently, how close your follow-up needs to be with them. Can you do that in a general practice? Or do you have the bandwidth for that? Or, do they need to be with you for sure?
Yeah, that's a really good point. And if someone were to choose in that nitric oxide pathway, there's sildenafil, tadalafil, and riociguat, which is a soluble guanylate cyclase stimulator, but very similar to the PDE5. So you would only choose one or the other. But when we use riociguat, we always cut their blood pressure medicine in half, give them parameters before they even start, because it's the most notorious for causing hypotension. And usually they end up stopping it really quickly.
Yeah. I would say probably 9 out of 10 of ours in just the ampersand and tadalafil, if not half, end up off their hypertensive therapy. So
yes, which is kind of nice because, they're adding more pill burden to them.
Yes.
At least sometimes we can take one away or maybe two.
I was just going to say that sometimes that's the carrot. Like, well, we can stop this medicine if we start these ones. So
right.
All right. Well, working at a PH center, as long as you get all of these referrals. I'm sure the majority of your patients are all referral based.
Yes.
So what do you see sent to you when you get these patients? Are there things that you wish would have been done before they got to you, or things that you see are commonly missed in the workup from general pulmonology or primary care?
Well, the first thing I would say is that despite a lot of educational efforts over these last 10, 20 years, there are still patients that get diagnosed with group 1 pulmonary arterial hypertension based on an echocardiogram. And we know that that's not a good approach, because 50% of the time it'll be wrong. They've shown that in two studies. So number one, most important thing, if you think somebody has pulmonary hypertension and you can get a good right heart cath, definitely do that, or send it to the Pulmonary Hypertension Center where they can get a right heart cath, but don't ever diagnose based on an echocardiogram. That would be the number one thing. And then as far as things missing, when patients have had a right heart cath prior to coming to the PH center, and it's a complete right heart cath where there's a wedge pressure and cardiac output and everything's done correctly, then the workup for that patient includes a VQ scan, a ventilation perfusion scan. And that's recommended in every guideline because it's the test that can look for chronic blood clots in the lungs, which coupled with pulmonary hypertension is what we call CTEPH, chronic thromboembolic pulmonary hypertension. And you never want to miss that because there's potentially a cure by undergoing PTE surgery. So VQ scans, if you're following along with what you think is a PAH patient, make sure that they don't have CTEP and get a VQ scan.
I would say that, again, a difference between general pulmonology and your organization is probably how quickly you can make a lot of those things happen. I know.
That's true.
Yeah, I think we tend to piecemeal things as we're going through the workup, and then, that could take us weeks to months sometimes out in the community to make happen. Which I know with you guys, you probably do it all at once.
Yeah, we do. So what we're doing now is this sort of new approach where myself and two of the other advanced practice providers are doing telehealth visits with all new patients. So we get their history, and then we order everything that needs to be done, the heart cath, the VQ scan, everything. And then they come in to the clinic and get all that stuff done and have a visit afterwards. So it's been pretty efficient.
That's very efficient, very efficient. Are there, other than the VQ scans and not using, I should say, the echo as a diagnostic tool, but more of a screening tool, are there any other road bumps that you see or common traps that providers fall into?
No, we do sometimes, have patients that get referred to us, and they do have group 1 pulmonary hypertension, and they get started on therapies before we see them, which is sometimes, especially if there's going to be a delay, completely appropriate. But if you're going to send somebody pretty quickly to us, it's really kind of nice if their therapies haven't been started, because we have a number of clinical trials that we can offer the patient, and sometimes those, require different combinations of drugs or no drugs. So we do appreciate that, but certainly if there's going to be a delay in getting them to the PH center, by all means, if you've got a right heart cath with PAH, then start treatment.
Go ahead and start. How about patients that may not be commonly screened, but that we should be thinking in general pulmonology need to be routinely screened for pulmonary hypertension? No previous diagnosis, maybe they had a normal echo 5 years ago, but should be routinely screened.
Yeah, the first thing that comes to mind and the most obvious is the scleroderma patients. So within group 1 pulmonary hypertension, there's subcategories, and one of the most common ones is connective tissue disease. And within connective tissue disease, scleroderma patients have a pretty high risk of developing pulmonary hypertension. So the guidelines for those patients are that they're screened annually, and sometimes that's done with this protocol called a DETECT algorithm that the rheumatologists use. And they actually do pulmonary function testing first and then look at that, because if patients have, for instance, a very low DLCO that's disproportionate to their forced vital capacity, then that would be a patient that they would then go on to do an echocardiogram, and then they look at certain echocardiogram parameters to decide whether to send them for right heart cath to the PH center. So that's how the rheumatologists often do it. We have a number of patients that we see once a year with scleroderma. We just repeat the echocardiogram every year. And then if there's any indication that they might have pulmonary arterial hypertension, then, of course, then we do the right heart cath. But when I say that based on echo findings, what I'm talking about are really three things. One, the estimate of the right ventricular systolic pressure. It'll say the RVSP, which is the same as the pulmonary artery systolic pressure on right heart cath. If that's above 40, 45, probably abnormal. The echo estimates aren't very accurate, though. So what's actually more important is the size and function of the right ventricle. So when you look at an echo and you think someone may have PAH or group 1 pulmonary hypertension, look at the right side of the heart. Is the right ventricle enlarged? Do they have right ventricular dysfunction? Those are really big clues or red flags that patient probably has pulmonary hypertension, especially if the left-sided heart function and size are normal.
Speaking of the left heart, I want to get into that, because I will say that those group 2 patients are the ones we get the most referrals on.
Yes.
Cardiology has identified some RV enlargement dysfunction, and their RVSP is elevated, but they've got diastolic dysfunction, their left atrium's enlarged, they've got grade 2, maybe diastolic dysfunction. And then, of course, they've got leaky valves to some extent, right? They've got mild to moderate TR and MR, and maybe even some aortic disease. So how do you really determine? I mean, I know the answer is going to be right heart cath, but how do you really? What leads you to believe this is more than just left heart? They also have an overlapping primary disease.
Yes, and this is where it gets to be the art of treating pulmonary hypertension, because it does get a little tricky trying to tease out in those patients how much of this is group 1, how much is group 2, because there's a lot of patients that will overlap, and we call that pre- and post-capillary pulmonary hypertension. And it's difficult. For example, if you have a patient that has any connective tissue disease or autoimmune disease, then we're thinking more like this is probably more group 1, for instance, scleroderma patients, but they also get diastolic heart failure. So you have to kind of look at what's predominant really. And on right heart cath, as you mentioned, we kind of feel like if the PVR is approaching 5 or higher, then it's probably enough out of proportion to consider that this might be a group 1 patient. But it gets really controversial, really, and can be under a lot of debate about how to treat these patients, because in some cases, medications, vasodilators for group 1 PH can worsen patients if they've got predominantly group 2 pulmonary hypertension. So this is one of the cases where definitely if you can get the patient to a pulmonary hypertension center, because it is really tricky and kind of difficult to figure out what to do with these patients. But one thing for sure is we would start with monotherapy and do this sequentially if we have somebody who has both group 2 and group 1 pulmonary hypertension. And one of the other clues is the left atrium. So if the patient's left atrium is normal, then we're thinking more group 1, but they got a big LA and the right side of the heart looks fine, then it's, that's one clue, maybe more group 2 disease. But it's a common and difficult to manage or, decide how to manage these patients.
Yeah. The echo, I think, does give you a lot of clues and maybe more, I don't want to say more accurate for left-sided disease, but definitely have to be cautious with the pressures that it estimates. We just had a case where this lady's RVSP was in the 90s, and she really didn't have that much RV dysfunction for being in the 90s, and that was definitely a clue. We had done her workup. Everything else was negative. No sleep apnea, no lung disease. Everything else looked very good. She ended up getting a right heart cath, and her pressures were like 28.
They're mean, you mean, or
yeah,
main?
Yeah. And so we were very dissuaded by the echo findings. And so you just have to be very careful with that, because they can underestimate as well.
Right.
And then that's when that's when the right heart and TAPSE and all that can kind of help you find that.
Yep. Yeah.
So back to selexipag. I wanted to touch on that one more time before we end, because that was a big game changer for a lot of us too, to have an oral option in that prostacyclin. We've had patients, I'm sure you have too, transition from being on IV therapy, to an oral therapy, kind of liberating them from their IV therapy to that. But it is a struggle. So can you talk to us a little bit about that struggle of dealing with selexipag?
Okay, yes. Selexipag, it is great because we have an oral option, right? We used to not have any oral options for prostacyclins, and then we had inhaled or IV or sub-Q. So it's nice to have an oral option. There's two, as I mentioned earlier. There's oral treprostinil, brand is Orenitram, and it's a prostacyclin analog. And then there's selexipag that we're talking about now, which is a prostacyclin agonist. It is dosed starting at a low dose of 200 micrograms twice a day. And then every week it's up titrated by 200 micrograms twice a day until the patient either reaches 1,800 micrograms twice a day or their side effects become too unmanageable for them. And then we reduce the dose to the prior level. One of the biggest things that we in the pulmonary hypertension community recently have started doing is not really being too firm on that weekly titration. So some patients need to go up every 10 days or 2 weeks, and we just have to make sure that we're being really flexible to give them the best option to get through this. also, we have a protocol for side effect management that we introduce proactively to the patient. So if we prescribe Selexipag, it's also an antiemetic in case they get nauseated. It's stop at the store and get an antidiarrheal. And in some cases, if acetaminophen doesn't work during the titration, we'll use stronger pain medications. But once the patient has gotten to the point, if they reach a point where they're vomiting and just, feeling terrible, then you don't want to try to push through that. And it's not like the higher the dose, the better, because they think that everybody has their own number of prostacyclin receptors. So it's not necessarily that a patient needs to have a high dose. It's very individualized. So we can even have patients that are on that first 200 microgram twice a day starting dose. And you kind of want to go, can't we get a little higher? But it's not necessary. And I think to be successful with Selexipag, you have to be flexible and don't think that you have to stick with that weekly up titration and try to push through anything.
So for people who maybe are sharing a patient with you, and you guys are titrating their Selexipag, but maybe they fall in clinic because they're having something that they can get right away with their general pulmonologist, outside the antiemetic and that type of thing. What are some side effects that you can say, well, I know that's from your drug and this is probably not, you should start. For example, I'll have patients come in and they'll say, I'm having joint pain in my elbows, just my elbows, nowhere else. I'm like, probably not related to the drug, not likely. But what are the really common, because I know there's a really funny rare one that happens with it.
Yes, the jaw pain. Yeah.
Mm-hmm.
So jaw pain is unique to prostacyclins, and it's a pain in the jaws with the first bite of the meal. Usually goes away after that first bite. It's a very strange side effect. I could say in 23 years, I don't think it's ever a dose-limiting side effect. Patients just figure out how to kind of live with that. And the same with flushing. We don't lower doses or not increase over flushing, which many patients have. But what does seem to get difficult is headache. Headache's very common. Diarrhea is really common. And oftentimes patients will have that long term. Some of these side effects get better or completely go away after they reach their maintenance dose. But it seems to me that most patients stay on some medication for diarrhea all the time. And then nausea is a problem, especially during the titration. Not vomiting so much, but if they're vomiting, you need to reduce the dose. And then body aches. You mentioned elbow. That would be unusual if it was just one elbow or just the elbows. But patients can have pain anywhere. And if they already have pain and then you start a prostacyclin, it's likely to make that pain worse. So pain is definitely can be a limiting side effect. And I think that's really it. Those that I've mentioned. And so if it's something outside of that, it's probably not a prostacyclin side effect.
Yeah. Okay. I think we could probably have a whole podcast on pH drug side effects and management probably.
Absolutely, for sure. Yeah.
All right. Well, we'll leave it there. Thank you so much for coming on today and sharing your knowledge about what's new in pulmonary hypertension and what things we could do better maybe as community pulmonary APPs as we're sending them your way. I really appreciate your time and thank you everyone for listening. Please subscribe and like the podcast, share it with your cohorts, and that is a great way to help support APAP. Thank you very much.
Okay. Thanks so much. Bye-bye.